Hello, Bhushan.
Hello, Dr. John. How are you?
How are you doing?
I'm fine.
Uh, Thank you for making it today.
Yeah, of course.
Well, I was going to ask you, you do private work, right?
Uh,
I,
uh,
I don't know if you do or not.
yeah, I do private work. But since maybe for next 1 year, I'm in Toronto. I'm doing my spine fellowship here with Dr. Michael Felling at the University of Toronto. So maybe not for 1 year, but previously I
Okay.
used to do, and
Well,
after that also I will do.
oh, you can point me maybe to someone, but I just want to basically know what I can do for the website. I
Mhm.
understand you can make a chat box or do other
Oh,
things.
yeah, yeah. That
So,
like
so just I'll get someone to do that. But you know, can you analyze the content of my videos? I have like 3,000 videos. Is there any way to mine data from those?
So I was thinking you are asking about private work in medical field, but this is like if you are asking about this, yes, this is okay for me to
Yeah,
do.
AI, yeah, AI. That's what I'm looking
Yeah, yeah, that I can do definitely. And analyzing 3,000 videos, yeah, it's gonna take time, but I can do it.
for.
I
Okay,
can do
I'll
it.
talk to you later about that. Okay,
Of course. Yeah.
but I do want to. I don't have the hands, the labor, but I'm told that AI can do a lot of things that
We can
help
do
the
it.
website, like maybe sending emails, maybe sending, arranging, whatever. We'll talk later.
Yeah.
There's Chandra. Do you know Chandra? He's one of the most distinguished neurosurgeons in India.
Yeah. Devapujari sir, right?
Yeah, he's a great guy.
Yeah, I worked with him for a few months.
Oh, he's a great guy.
Yeah, of course.
He did a pediatric conference for us once.
Yeah.
And I'll ask him if he wants to be first, if you don't mind.
Yeah,
Okay.
yeah, of course.
Yeah.
Yeah.
Chandra, you there?
Yes, John.
Hey, welcome. Thank
Good
you.
morning.
Good evening, sir.
Hi, Bhushan.
Hello, sir.
How's,
You guys
how's the
work
Canadian
together,
weather
huh?
treating you?
It's so far so good, sir.
Good, good. Looking forward to your talk.
Yes, sir.
I'm
You,
sure you must have added some spice to it.
Yeah, almost same talk what we did in MCNS because I think he wanted it for some younger generation to get it. But few points I can explain better because of time, maybe.
Great.
Yeah.
Chandra, you go first, okay?
I'm good. You want me to try sharing?
Not now. We're not ready yet, but once we're ready, you'll go first. I'd like you
I'm
to,
ready.
I'd like to introduce you first with your full face.
Uh, I think I'm ready.
Okay.
I
Okay. We don't
I
start.
hope people like I'm just trying to explain a few things to my journey and whatever I'm doing. I'm a neurosurgeon, John, but I didn't start as a pediatric neurosurgeon. I did my vascular skull-based fellowship before I went to pediatric as the at that time that was more popular and we thought it was the more attractive thing. So it's been a jack of everything.
Well, I'm not around a hospital, but I imagine things are changing.
Oh
Education,
yes, very fast, very fast.
yeah, very fast now. It's like, whoa, man, it's hard to keep up. But hopefully you'll tell the youngsters what's important, really,
Hmm.
in your mind as an experienced neurosurgeon. What do you see happening? You know,
Yeah, I'll try and put across some of my ideas and what we have through what work we have been doing. Bhushan has helped us a little bit and he's still trying to do something for us.
okay.
Uh, and I'm sure that it will uh, sort of take his time, but he's quite good as it managing and creating things. So I'm sure you'll like his talk as well. The Victor I know very well. The young lady I have not heard before. So I'm
Pathology.
where is she from, John?
Pardon me? She's
Where
from
is she from?
Mumbai, I believe.
Oh,
I think she is. We'll ask when she comes in. She should be in here pretty soon.
she must be in Tata then, because not many
Hey,
people know
Victor.
her.
Yeah,
Let's hear
pathology's not a
out.
big subject.
So you want me to go first? Is that what you said?
Yeah, if you don't mind, okay?
No, I'm fine with it.
Yeah.
Hello.
Hey, Victor, welcome.
Hello, Victor.
Hello, Professor Chandrasekhar. Very nice to see you. Hello, John.
How you
Yes,
doing?
long time I spoke to you, but nice to see you
Very nice to see you again.
in a beautiful color.
Yeah,
Thank you.
he's pretty active on the internet.
Yes.
He spends a lot of time in India. You seem to go to India a lot, Victor.
Excuse me?
He's been there. You've been to India many times, right?
4 times, 4 times.
Only.
I saw you there
Beautiful,
once.
beautiful country, especially their people. Very, very kind people, like in Mexico.
The young generation is all
We have similar things, the food, the people, our roots are similar.
absolutely.
Yep, those tacos are something else. I was there 2 years, Victor, before I even tried a taco in Mexico. But once I tried them, I was hooked.
When are you visiting India, John?
India, I was India. I didn't get to know the food very well.
Mhm.
I'm trying to remember the soup, what I liked in Bharatnagar, Nepal, which is very similar. Momo, is there momo?
Momos are, yeah, momos are
Was that
I mean,
Indian?
I think it is Chinese food, but it is adapted to Nepalese and to some extent now even in West, well, Northeast India.
Okay. Okay, we'll start 10, 9, 8, 7, 6, 5, 4, 3. Good morning from Miami Beach. This is Dr. John Bennett broadcasting, home of Neurosurgical TV. We have an exciting new webcast, Neurosurgery Aspirants, students that like neurosurgery and consider going into it as a career, and all med students or neurosurgeons have been there at one point, and hopefully we have speakers that enlighten the time right now. And the first speaker is a gentleman I've known for a while. He's been doing these webinars for 8, 9 years with me. He did a long series of pediatric neurosurgery webinars. Excellent. I'm trying to get him to do more, but whatever. But anyways, Chandra, it's all yours, and just introduce yourself and your topic. Thank you.
Thank you, John. You think I can share my talk now?
Sure.
So is that visible?
Not yet. Not yet.
Not yet.
Not yet. Okay, make it large. Yeah, perfect. Perfect.
So let's start. Good morning, good afternoon, good evening, depending on where you are. And John asked me to give this talk in his series for aspirants, young aspirants, and gave me the title of the Tsunami of New Technology in Neurosurgery, with which I have been, struggling all my life. So I thought I'll start with my life story. before we actually get into the nitty-gritty of new technology. Oh, why is this happening? Not able to move forward. So why do we choose neurosurgery? After becoming a medical student in India, we cannot directly choose a specialty, at least in my part of the world, because India is a huge country and many states have different norms. But at the time when I cleared my medical graduation, you could not directly do neurosurgery. You had to do general surgery uh, course first, and then when you completed that successfully, then you could apply for neurosurgery. So many of my friends, even my family, asked me, why do you want to do neurosurgery? So I thought it was a relatively unexplored area. This is in 80s. Uh, and I thought it was very clever to be a neurosurgeon. Um, Most people still believe that. Uh, and it is highly specialized because we are now developing so many subspecialties. We realize it today, but that time it was a dark period because CT scans were just discovered. And you can imagine uh, what we didn't see, we couldn't do very well except for a few exceptional people. And it was highly specialized. And I thought at that time maybe there will be less physical work and more academic research. But I think it largely depends on your mentor. And I found a good mentor in Professor Bhagwati, who was in Mumbai, who was very keen that I did neurosurgery from some of the contacts he had with my family and friends. And therefore, I started in neurosurgery in 1981 at the JJ Hospital, which is the oldest hospital in Mumbai. And for a neurosurgery, what did we actually have? We had a ward, men and women were in separate wards, and we had about 35 people in each, but we only had a 4-bedded ICU. And the only monitoring that was available was ECG monitoring at that time. Uh, and there were some ventilators which were pressure regulated, and no anesthetist wanted to attend ICU. So we had to learn all these things ourselves. We had to even draw blood from patients because there were no techs available. And except for blood gas analysis, which was done by one technician in the whole hospital, mainly appointed to cardiac, we had to do. And there were no other medications except for Lasix, mannitol, and steroids, and some hyperventilation, which we started. The sedatives were very few. There was no CT scan. It had just come to Mumbai, but it was not in the campus. It was in a private setup. And the ultrasound was used only to see if there was any midline shift for the trauma patients. And you had to do all funny things. You had to do some of the lab investigations to clear patients for surgery and help in OR in emergencies without even knowing what you are trying to do. But during this time, I was allotted a topic of, correlation of Glasgow coma score with patient's outcome, because we used to get a lot of trauma. Mumbai, apart from the usual road traffic accidents, has a very peculiar kind of accident called local train accident, because the trains in Mumbai run without a door, and many people who are standing, they fall off the tracks. And there is even today, I think about 3 or 4 people lose their life every week. And this was something which made the hospital full with trauma patients. And therefore, we had less kind of elective surgeries. But there, the GCS had just been introduced. And uh, I was fortunate enough to create for our ICU staff and ward patients, we created a chart for observing these patients, including Glasgow coma score. And many of these things have become now a standard part of intensive cares all over the world. And this was recently when I met Professor Teasdale with my wife in one of the meetings. Operation theaters, one operation theater was with microscope, another was without microscope. It was just introduced. Only one of our teachers out of 3 could use the microscope to some extent. And you had to do alternate day invasive investigations, because most of the diagnoses were made on ventriculograms, direct puncture angiography. So that's how we learned our vascular anatomy. Pneumoencephalograms, if the patient did not have too much raised ICP, rather than doing a ventriculogram, you would do a pneumoencephalogram, and even myelograms had to be done by yourselves. There were two other benefits though, because we did not have much imaging apart from this indirect kind of imaging. The brain cutting sessions with the pathologist did were very important for our solid anatomical foundation. And later even surgical microanatomy when we tried to examine the same specimens under the microscope. In OR, you hardly got a chance during your first year to be a first assistant. Later on, it happened during your last few months. And there was very little use of operating microscopes. There were no self-retaining retractors. You had to hold a retractor in your hand all from dural opening to the end. And it was really difficult because you couldn't see what you were holding under the retractor. Bipolar cauteries were not available during my first year residency. They became available only later. And the only local hemostat available was gelatin sponge. And apart from that, I think the whole training system was such that we were still following Halstead's principle, which are very sound though. The resident must have intense and repetitive opportunity to take care of surgical patients under the supervision of a surgical teacher, which is your first job. Second job is you must acquire understanding of the scientific basis of surgical disease. And then only you are ready to acquire skills for patient management and technical operations of increasing complexity with graded enhancement, responsibility and independence. And not only we had to understand that, but all our teachers knew it very well that this is how you are going to do it. And if you said anything, if you asked any question, the only thing that was told to you is that we did it this way and you have to do it this way. The only good thing that happened was my mentor, who was already a well-known internationally, had contacts, not only contacts, but he was very friendly with one of the Indian neurosurgeons in UK. And he also put me in touch with Dr. Ausman and Dr. Yasargil. And I managed to go abroad within a very short time as soon as I qualified to learn further neurosurgery. But the principles remained the same till I returned in 1989, that is after 3.5 years of training and virtually 4 years. And by this time, MRIs had become available. The neurointensive care started very, very earnestly. And the main workload was there for the tumor hydrocephalus and spine. And I had mainly learned vascular and skull-based tumors. So there was a little bit of issue in adjusting with day-to-day work, but it was still enjoyable. I also worked at Hinduja Hospital for a while, which was a sort of more advanced care hospital, and where ICP monitoring I got used to. They also bought a gamma knife even during that time, the first in India, and I learned stereotactic radiosurgery also. And one of my colleagues who was very keen on pediatric epilepsy surveys, I learned epilepsy surgery with a short trip to Miami where he was trained, and we started doing cases at that time. So apart from pediatric epilepsy surgery, I also got attached to a hospital. In fact, I not only attached, I started a department at the local municipal hospital, which was Asia's oldest children's hospital. We'll be completing, we are in our 99th year to be precise. And Dr. Bhagwati organized a course where the International Society for Pediatric Neurosurgery used to come and teach us. And we started with virtually nothing, an occasional surgery. But today we have a dedicated operating room. I have 4 colleagues who are working with me as consultants, and we have 2 fellows being trained every year. And during all this time, the progress was happening. There was advanced imaging and navigation, DTI, fMRI, new sequences of MRI were coming, neuro navigation systems were coming. Our hospital was one of the first one to buy it. Minimally invasive and endoscopic techniques, especially because I was treating children. I was interested in doing, we used to do a large amount of shunts. I was interested in learning endoscopic third ventriculostomy, and neuromodulation was another another type of treatment which was developing for various things like stem cell therapy, and deep brain stimulation was being just introduced. So the question was, how do you cope up with this? I mean, you just keep on training all your life. But fortunately, I got a short fellowship in Minds with Professor Yasargil, so I didn't go for neuromodulation. I went instead to learn neuroendoscopy in Germany, where Axel Pernesky and later who became my friend, Professor uh, Grotenhaus, have actually taught us many aspects of minimally invasive neurosurgery, which was extremely popular in 90s and which has become my main job since then. And I got, as soon as I came back from this fellowship, I got an associate professor's job. So I was in a academic unit, and we also developed skull-based neurosurgery along with my ENT colleague. And this was one of the first centers we started doing it. And we could actually therefore get a lot of work in this field. All this time, the operation theater was changing. The neuronavigation had come. You had several other things which were trying to tell you to be very precise. You also had now certain models which could be used for training before surgery. And the old concept of see one, assist one, and do one had disappeared by the turn of the century. So how do you integrate the roadmap for learning, as well as now I am responsible for students? So I think what technology to integrate becomes very, very important. So we first thought we should have navigation because of proven efficacy, and they were definitely relevant. And then promising tools, like you need to have, proper drill systems, and you learn as to how to use this potential of these technologies. And I mean, just one example of endoscopic pituitary adenoma, which is a surgery we were one of the first ones to develop. So I might come back to that example from time to time. And you have to, therefore, for teaching, you have to develop modular curriculum design. You have to also have a tech infused assessment, which is being largely neglected in India. You only have one exam at the end of your course. Now it is, of course, changing. And global collaboration, the fact that I could get an opportunity to train in UK and US made it easier for me to do that. And then you develop your clinical workflow. So you need decision support tools. AI was, of course, not developed, but use neuroradiology platforms. That was the main thing, which, and in after that, even with navigation. And then you have to actually create data-driven protocols. The data preferably should be your own. Otherwise, you can, of course, compare it with large series or meta-analysis, which were not available at that time for something like endoscopic versus microscopic pituitary resection. But we found that our hormonal results were better, our CSF leak rates were better. And after you develop this surgical integration, debrief your students as well as the OR staff so that you become more effective. I also did it myself, and I always encourage my younger colleagues as well as students that publish and present. That tells people what ideas you have, what is your experience, rather than just saying that I'm doing 100 cases of this. If you have presentations and publications, you can probably present yourself better, and you understand your own, pluses and minuses much better. Mentorship networks. This was possible to create now with digital technology, internet coming into India. And at this time, I became part of two main organizations, the Indian Society for Pediatric Neurosurgery and the Neurological Society of India, which is our sort of mother society for all neurosurgeons. And then you can contribute to the policy as well and teachings. So learning objectives like in endoscopic pituitary were anatomical orientation, procedural steps, respond to common intraoperative challenges, and postoperative outcomes. And me and my colleague who were involved in this surgery, we tried to do as many workshops create workshops in our own institution at least once a year, where we would do cadaveric workshops as well as we will do um, operating sessions by well-known surgeons in this area. So I think you have to develop foundation. The main problem was developing technical simulation. Complication handling, I think by experience and by showing a few cases you can do. An outcome review is something very important which you need to do virtually every year. So how do you then decide how the trainees are to be taught? So novice needs, of course, tutorials, instrument handling practice, etc., intermediate and advanced. And then you do your performance analytics, decision-making metrics. Also, you have to use and reflective journaling, which is again lacking even today in India. And then if you are really doing something which is you think should be sort of told to the world, then you should have a, or at least your own country, you should have a low bandwidth versions for resource limited centers, offline exportable modules for sharing learning in community hospitals, and multi-language voiceovers. I mean, John has done a great job in developing, now such a big, probably, I don't know what to call it, library or whatever, of so many neurosurgical material. And low bandwidth versions in limited resource countries have made him extremely, extremely popular. So we looked at what we could do to teach students. And ETV simulator was first thing which we tried. Actually, in 2017, just when we were trying this, another paper came with 3D printing technology, which had just become available to us. But we could not use it consistently because it was very, very expensive. And there is a lack of haptic feedback. That's why whatever we tried, we were ourselves not very happy. So the next thing was, can you do a virtual reality? Again, the same problems come. You miss the complete haptic feedback, though you can actually have an immersive experience if you have a good video quality and you have somebody who can create that. So we thought of making physical simulation models, and we thought of using either animals or synthetic models. And you could do most of the core skills teaching during this time. And we tried to do very, very simple things with this. We started with endoscopic, just pick up and sort, which is extremely good for hand-eye coordination in our lab. We started other things like, this is used when you can use a Caesar, pick up separate it like a dissection, and then you can pick it up. We again did the nasal anatomy simulation on created models by us on the silicon models available. And then we also did eggshell drilling, which is a well-known exercise developed several years ago. And then we developed our own dynamic simulator for endoscopic intraventricular surgery. Such a system is still not available, the dynamic one. And unfortunately, we can't send it out of India, though I have had a fair amount of uh, demand from some of the seniors. So our boys here around foramen of Monroe, a good septal vein, thalamostriate vein, and choroid plexus from animal tissue. And this, I'll just show you a small video of how we will give you an idea how realistic this is. So you can actually go through the foramen of Monroe, you go into the posterior third ventricle, you put your Fogarty catheter into the aqueduct, and you can dilate it. These kind of exercises apart from ETV were done. We did the same with nasal stage of the endonasal surgery. You could actually create a model with a good sphenoid sinus. Now they are commercially available. Initially we had a problem. You could actually use drilling exercises, and we created a good pituitary for our delegates, and we created optic chiasm and a carotid bleeding model, which you can see on the side wall, and you can get a good experience of what can happen. And we managed to teach them either by using a clip or by using some local hemostat how to stop it. Of course, the biggest disadvantage is you don't get the chemical which usually release in a live person, but you can still manage to teach them if the cut is short or small. We also created a spinal endoscopy setup, and from a pig model, we tried to do interlaminar as well as foraminal approaches. And on the same things, using a C-arm, we started using pedicular screws as well. So this was the creation of another model. You can see the nerve roots. So we created these three models and they have become very popular. About 600 people have been trained so far in the last 10 years on them. Augmented reality is something which not many people are using, but it is now possible to use with standard MRI images if you do a 3D reconstruction. And this is one example for a parasagittal tumor. Chemical imaging has come up. So now today, you not only know which is the tumor more clearly by only imaging, you know which are the more aggressive areas and take a correct biopsy, or it helps you in diagnosis as well. Another imaging which has come is the DTI to make safe corridors. And like you can see here, for this brainstem glioma, we could create a safe corridor by going behind on one side of the tumor and manage to remove this tumor completely. And now if that was not enough, we have now connectomics. An atlas of connectomics tells you what other important functions lie there. And the SCP parcellation atlas has become a guide in many centers today, which can tell you about 200 different functions of the brain and how to save them. So the workflow is dependent on the atlas, and you need to have the MR sequences which can be used in the connectome project. The main application in neurosurgery is how not to lose function while doing your surgery. This is actually given by one of my friends, where for this tumor, patient presenting with torticollis, we decided to use the telovelar approach rather than complete lateral or midline approach, and there was no postoperative cerebellar mutism. Robotic assisted surgery has also become a fact of life, which is being used in vascular as well as tumor surgeries. But the visualization is the main thing that is performed by most of the neurosurgical robots. I think except for anastomosis, there is no other robot which is doing successful tumor resections unless they are being done some on an experimental basis in some departments, academic departments. But your visualization and navigation becomes has brought another dimension to it. So you need to have a good trained physician, physiologist for these kind of things. And as not many people are trained in these ancillary branches in India, a lot of burden comes on junior consultants and residents to learn and to interpret this data. But this is something which we are now using for about 10 years. Intraoperative image enhancement has also come, which tells us the integrity of the vessel, your functioning of your anastomosis, and in tumors, you can delineate them better with either 5-ALA or this green fluorescence with microscope as well as with endoscope. So how do we stay ahead without falling behind the technology, as well as you can understand that every hospital can't afford all the technology? So the idea is not to consume, but to curate. Focus on technologies aligned with your subspecialty. Use structured filters. Integrate this into training. Embed simulation, VR, which we have been able to do. AI, I think Bhushan left early for his fellowship, otherwise would have probably used him to create some protocols, and tailor assessments to match evolving competence. Most importantly, collaborate across disciplines. It has become extremely important. The radiologist has become an important part of your team. The electrophysiologist has become an extremely important part of your team. Champion ethical and equitable adoption. I think that is very important, especially for senior people. As you grow senior, you have to advocate accessibility in research, low resource settings, push for validation studies across diverse populations. And as I said, I am very keen that younger people do this, attend global conferences. Now you have a chance to attend virtual conferences as well. Subscribe to journals. Well, you need not subscribe. They are very expensive, but most digital versions are available and your libraries use it as well. Just because everything is available on Google or some of the search engines, I think that is not enough. And balance enthusiasm with skepticism. Not only ask what is new, but what works. I think in all this, we cannot forget that there is a never-ending dilemma during all your growing life, even growing life in neurosurgery. Service versus academics is a big problem in India, where it is not very easy to get attachment to an educational institution if you are in practice, if you want to practice. What is the need versus what is your interest that you have to see in the department, in the hospital you work in. And the biggest dilemma for a neurosurgeon with extended hours of working is work versus life. Are neurosurgeons special? I specifically like this editor of AANS Neurosurgeon Ladies editorial some years ago, when she said that when she was deciding about taking neurosurgery, where you had to work virtually 80 hours a day, this is about 20, 25, 30 years ago, to other specialties where you had to work 40 hours a week. Her parents were not very keen, but her grandmother, who had not even gone to school, she says, said that it is better to work 80 hours a week at something you love than 40 hours a week at something you hate, and convinced her parents to let her do neurosurgery. And Dr. Harbog, who has been president of AANS, said that marking time for yourself, uh, I mean, one feels guilty, actually, most of the neurosurgeons. But I think work-life balance is beautifully explained by Federer. I'm sure everybody knows this great tennis player. He says that I find the term work-life balance confusing. It suggests that our work is somehow separated from our lives. However, our work is an integral and very rewarding part of our lives. And therefore, work is life is, many people say between the age of 25 to 60, that should be there. It is even in some scriptures in Indian religion. And this is one of them. Why do you have a hard life? One of the disciples, famous disciple, asks the, well, not the deity, but Krishna, who's supposed to be a mentor of Arjuna, who fought the Mahabharat war. And he says that only if you have gone through hardship, you can shine better. And that's how God looks at you. Having thought of all this, one of the things I have realized is that having colleagues who understand you and rely on you, and you can rely on them, is one important part of your working career as well. We lift each other from the lowest lows and celebrate the highest highs. Professor Yasagil said when he developed microneurosurgery that our ability to continue to rely on old paradigms is questionable. Conceptually innovative ideas relating to individual surgical anatomy, neuroimaging, neuropathology, all these are, the way they are growing, we really wonder that how did we stick to dogma earlier. Each surgical action comprises not only science, experience, knowledge, and techniques, but also artistic, philosophical, and religious attitude of the neurosurgeon. And he came and taught us for 2-3 days over a weekend, 2 days to be precise, but virtually 8 a.m. to 8 p.m. And the whole audience of about 250 neurosurgeons was glued to him. Passion in teaching also makes the teacher, more sort of reflective on what he's doing and probably understand from the questions as to how people are thinking and what needs to be addressed. And I thought one of the best things about the master was he was equally curious about everything, photographing, cataloging. It was virtually impossible to stop him doing all this. You realize that most of these things have become virtually obsolete. So you need to keep on developing. This is a recent paper by Schwartz from New York, where he analyzed 1000 consecutive endoscopic endonasal skull-based surgeries and talked about how long is the tail end of the learning curve. And he demonstrated that contrary to popular belief, the surgical learning curve does not plateau, but can continue for several years, depending on the complexity of the endpoints considered. So where will we be in next 40, 50 years? I really don't know. I am sure the surgical technology will improve, but the indications for surgery may reduce. So we have to be prepared for that. And I think we have to embrace this challenge. The biggest problem is, especially in low resource countries, is it is becoming very expensive with embracing all the new equipment. And that is something which I tried to address during this. So I think we have to learn from the past, think about the future, but live in the present and try to do our best. Thank you.
Thank you very much, Chandra. Very good. Okay, excellent, Chandra. Thank you for putting the time in. And now we're going to open the floor for questions or comments. I see we have another Mumbai.
Thanks, John, for this opportunity. And I hope I inspire people rather than, getting them away from neurosurgery.
Well, it's all part of it. Any comments? Harshad, another Mumbai resident that you probably know, Chandra is here. Hello, Harshad, welcome.
Hi, John.
Hi, Harshad.
Hi, Shekhar. Excellent talk, very stimulating, and you have addressed it so well and so beautifully that we have to learn, learn, and learn. And learning has no end, no age bar. So this is another stimulation. It is not a simulation, I would say stimulated. We are stimulated. You have put it in a very, very beautiful way. I really admire your efforts to bring it out in a complete way. And you have not untouched any area of the neurosurgery. Wonderful, right up to the robotics. Superb. And yes, we have to learn. We have to keep our eyes open and learn and live in present. But we can't forget our past also. Yes, it was a wonderful conference, the 2 days meeting when Professor Yasser Gill was there, when Dr. Bhagwati had arranged that. And I was one of the presenter there, not as a presenter, but I was a visitor there. And we really thoroughly enjoyed, and his enthusiasm was superb to teach us. Superb. 2 days of the feast of learning. Very nice, very nice. Thank you.
Thanks, Harshad.
Thank you, Harshad. Anyone else have a comment or a question?
Thanks, Professor Chandrasekhar. Really nice lecture. Amazing. The relation between the past, present, and future. Really, really interesting. I am very sure that I am going to repeat your lesson to see it again through Neurosurgical TV several times.
Victor,
Really
I think
nice lecture.
most of us who are trained before 2000 found the transition quite alarming, but I think we managed to cope with it. And I'm sure now it will be easier to cope with it because dissemination of information and training methods have improved.
Yes.
Yeah, I have a question, Chandra. I'm not a neurosurgeon, but how much is robotics?
I am sure you can be certified now as a neurosurgeon.
Yeah, well, I can't operate yet. But anyways, I loved hearing about it, and I like to see the new things happening because they're all new to me too. Do you see much robotics in most of the hospitals you go to, or is that something for high-priced senators?
I think robotics in neurosurgery as actually a operating robot is restricted today only to vascular anastomosis, and that also on the surface. I think the complex anatomy of the brain has still not allowed us to do that. The main thing which that has developed in US, Canada is the visualization robots, and they are allowing you to work now with exoscopes. You do not have to strain your neck with a microscope. I think the younger generation will probably take to that, and visualization robot will give you the precision which navigation was giving you, maybe much better. Things like epilepsy surgery, where you have to put, say, what they call depth electrodes. If you have to put 30 or 40 of them, I think without robotic help, it is not possible. So these are some of the areas where it is being used or where micro manipulation is required. like some of the endonasal surgeries or some of the, if you decide to do a tumor surgery with endoscope, maybe these manipulators will help us. But I can tell you, if Bhushan is with us, he can tell you a little bit better because he has also studied this subject, or he will probably come out with his talk.
Yeah, you know, when I heard Dr. Ben from China say that artificial intelligence is the future of neurosurgery, I didn't understand what he's meant. This was 3 or 4 years ago he said this.
Uh-huh.
But since then, in the last 3 years, uh, robotics has improved so much that it's going to be part of neurosurgery. I was surprised completely.
I'm sure it will become. The only problem that remains is that I mean, it will all depend on. See, we are so dependent on depth. We are so dependent on opening up folds of the brain, opening the cisterns or the crevices of the brain. That kind of a precision to come in a robot, I'm sure will be possible. But everything depends on the what data you feed, and that kind of a 3D atlas to feed in the computer or on every patient who is going for that kind of surgery. I don't know how long it will take. Currently, it looks very difficult, but it may become possible soon.
I'm sorry, Chandra, I muted. Yeah, we look forward to that. It's an exciting time in neurosurgery. We look forward to it. And I'd like to thank you for spending the time. I look forward to your next lecture. Thank you very much. Okay,
Thanks.
the next
Thank-
speaker, Umay Khan, she's a pathologist, and I thought she was from Mumbai because there's so many people from Mumbai here, but she says she's from Hyderabad. So
Oh,
welcome, Umaya. Are you there?
Yes, sir. Hello,
Okay,
good evening.
it's all yours.
Yeah, I'll share my screen.
Okay, you're working on
Yeah, just a
it?
second.
Okay,
Can you see my screen now?
not yet.
Okay, now?
Not full screen.
Yeah,
Okay, make it full screen. Perfect. Okay.
okay. Good evening, everyone. This is my third lecture uh, about neuropathology. And I'm here feeling very anxious because there are so many my senior neurosurgeons are here. So please, if there is any mistake, please excuse me. And anytime you can stop me and correct me if I'm wrong. I'm a assistant professor, just so very new in my career. I'm trying to present to the residents or new medical students. I'm just giving the introduction of the neuropathology. So this is my third lecture, which uh, is about CNS infections and demyelinating diseases. Um, CNS is, as we all know, that it is protected by the skull, meninges, blood-brain barrier, and by the immune privilege. And infections reach CNS via hematogenous, either by direct implantation, which is very rare, and or by local extension or peripheral or through the peripheral nerves. And clinical features are is either fever, headache, neck rigidity, altered mental status, or seizures. And there are various diagnostic tools. The basics are the CSF analysis, neuroimaging either by CT or MRI, and in difficult cases we do biopsy also. So I start with bacterial meningitis, which is caused by the common pathogens which cause bacterial meningitis is E. coli, Streptococcus pneumoniae, Neisseria meningitis, and Listeria monocytogenes. These are the common bacteria which causes bacterial meningitis. And in histology, what we see, this is the gross image where we can see there is exudates on the meninges, and here we in the microscopy we can see there is neutrophilic infiltration of the meninges, and there is this is the vessel, and there is inflammatory infiltrate around the vessel, and thrombus formation. Complications can occur which causes hydrocephalus, infarcts, and cranial nerve palsies. And in CSF, what we can see in the bacterial meningitis is there will be high neutrophils. As we can see here, the number of neutrophils will increase. And in biochemistry, we can see the low glucose levels and high protein, and which the infection can also be confirmed by gram stain and culture. Next, I come to the brain abscess, which the brain abscess is defined as a localized pus due to pyogenic bacteria, either by like the foci of infection can be through the endocarditis or sinusitis, etc. And how can we how we diagnose is by imaging. And in MRI, we can see that the ring enhancing lesions in the MRI. And histology, we can see the central areas of necrosis, granulation tissue, and fibrous capsule around it. This is the image, MRI and CT and MRI image of a 24-year-old woman with presented with 3 days history of increasing headache followed by seizure. Here we can see that the ring enhancing lesion, which mimics as METs also. There are different DDs of ring enhancing lesions in the in the brain, one of which is the brain abscess, and also it mimics the metastasis because it also occurs at the junction of the gray and white matter. Here we can see that the central areas of necrosis surrounded by this ring, fibrous ring. Next, we come to the TB meningitis. In the TB meningitis, this we more commonly see in India, where on the gross imaging, we can see in this gross, we can see in the autopsy cases, where we can see that there's a basilar exudate, which is whitish in the cerebellum and the brainstem. In the microscopy, what we can see is the caseating granulomas, caseous necrosis, which is surrounded by these epithelioid histiocytes forming granulomas, and these are the Langerhans type of giant cells. And there also can be vasculitis and hydrocephalus as a complication. And another special stain, which is a Z-Nelson stain, which identifies the acid-fast bacteria, Mycobacterium tuberculosis. Here we can see that here as a Mycobacterium acid-fast bacilli in the AFB stain. Next, we come to the viral encephalitis, which is caused by, first we see the HSV, herpes simplex virus. Again, in the grossly, we can see this in the autopsy specimens of the brain as temporal lobe necrosis here. And in the microscopy, what we see is the cow type A inclusions, as we can see here, central eosinophilic material, which is intracytoplasmic or intranuclear, and and there are hemorrhagic lesions. Next, we come to the CMV, cytomegalovirus. In this microscopy, we can see that the cytomegalic cells, these are the enlarged cells of the CNS, which shows intranuclear and cytoplasmic inclusions here. All the cells are, we can see that they're enlarged and shows these intranuclear and intracytoplasmic inclusions. We called it as CMV inclusions. And on the special stain immunohistochemistry, we can by the CMV antibodies, we can highlight these cells. Next, we come to the rabies, which is spread via the nerves through the which is called the centripetal route from nerves to the brain. And this very characteristics of rabies is these negri bodies, which are in the intracytoplasmic bodies, which is seen in the hippocampus and in the Purkinje cells. This is the very important differential diagnosis in the CSF. As we see, we can differentiate on the CSF that either it can be either viral, bacterial, or tuberculosis only based on the CSF analysis. By the appearance, we can see in the normal CSF is clear, and in viral, it is usually clear or slightly turbid, but in bacterial and tuberculosis, it will be either turbid or purulent. Then opening pressure will elevated in the bacterial and tuberculous meningitis, and WBC count is also relatively more in the bacterial and tubercular meningitis, not as much in the viral. So if we are seeing more counts in the CSF, we have to rule out either bacterial or tuberculous meningitis. And again, the glucose levels will be less than 50% in the bacterial and tuberculous meningitis. So the close differentials between bacterial and tuberculous. Protein levels will be more in again in the bacterial and tuberculous meningitis when compared to the viral meningitis. In microbiology, we can see as we cannot extract the virus from the CSF, usually it will be sterile. And in bacterial and tuberculous, we can retain the organism by culture and by, as we have seen that by Zn staining, we can see the acid-fast bacilli in the tuberculosis. Then we come to the HIV virus. In the HIV, we can see that the brain can show microglial nodules. Microglial cells, as we have seen previously, these are the macrophages in the in the brain, CNS. And these cells form these nodules in the brain, and also there will be multinucleated gene cells around these. And this can cause HIV can cause the progressive dementia. This is the classic HIV encephalitis, which shows the cluster of microglia and gene cells in the white matter. And this is the special stain immunohistochemistry with HIV P24 within the microglia. Next, we come to the progressive multifocal leukoencephalopathy, which is we call it as PML. It is caused by the JC virus, which causes demyelination of the oligodendrocyte, demyelination because it affects the oligodendrocyte. And since we know that the oligodendrocyte is responsible for myelination into the CNS, this virus this attacks the oligodendrocyte, so it causes the demyelination. And it also causes the inclusions in the oligodendrocytes. And also there will be foamy macrophages around this. So this will be this will be seen in the JC virus. And again, the diagnostic tools will be CSF PCR for JC virus and MRI brain and brain biopsy. This is the T2 weighted MRI image, which is showing progressive multifocal leukoencephalopathy. Here also we can see that the gross imaging, which is showing gray demyelinating foci, this confluent demyelinating foci. And this is the microscopic image, which is showing intranuclear. Here we can see that the intranuclear basophilic or eosinophilic inclusions within the swollen nuclei. And there are large, occasionally multinucleated cells here. Multinucleated astrocytes with prominent processes are another characteristic feature because these are the reactive astrocytes which increase in size. And this is the SV40 IHC, which is are the positive in these cells. Next, we come to the fungal and parasitic infections. Among the fungal infections, Cryptococcus is most common, which is seen in the immunocompromised patients like AIDS. And on the imaging, it gives the soap bubble appearance. Like this, we can see the multiple tiny soap bubbles like appearance in the imaging. And in the microscopy, this appears like a round, disc shaped, round, translucent. These things we can see here are the cryptococci. And we can also diagnose it by the special stain like Indian ink stain and mucicarmine stain. This is the Indian ink stain which shows which stains the capsule of the cryptococci, and this is the mucicarmine stain. Next, we come to the aspergillus or mucor. These are the angioinvasive fungi. As we can see here, the vessel is all filled with the fungi. And this is a very dangerous infection which spreads very rapidly. And this causes the hemorrhagic infarcts in the brain. And this also occur in the immunocompromised people. Here, this is the broad branching branching filamentous fungi, which is the mucor. And here, this is the large acute angle branching, which is seen in the aspergillus. So this is the mucor, and this is the aspergillus fungi. And this is the special stain, GMS stain, which highlights the both of the fungi here. Then next we come to the toxoplasmosis, which is a parasitic infection, which causes the necrotizing abscess with the bradyzoids and tracheozoids in the brain. And this also occurs in the immunocompromised individuals. Here we can see the biopsy image, which shows this polymorphous inflammatory cells in the background. These are the eosinophils. Since we know that the eosinophils will be seen in the parasitic infections, here we can it is highlighted, and these are the bradyzoids and tracheozoids of the toxoplasma. The diagnostic tools will be again PAS stains or GMS stains, and culture and PCR serology. Next, we come to the prions disease, which causes rapidly progressive dementia, myoclonus, and spongiform change, which is without inflammation. This here we can see the gross image of the brain, where there is a spongiform changes there. This is caused by the prions disease. And in histology, we see that the spongiform vacuolation of the neuronal. We can see that the vacuolations here, vacuolation and neuronal loss and astrocytosis. Astrocytosis means there will be increase in the reactive astrocytes. As we can see here, there are so many reactive astrocytes which are increased due to as a reactive change. And here we can see that the PRP plaque formation in the immunohistochemistry image. Diagnostic tool again will be here EEG as periodic sharp wave complexes And as neurons degenerate, there will be this protein, 14-33 protein, which leaks into the CSF. As this protein is present in the cells, when neurons degenerate, this protein leaks into the CSF, and we can diagnose it in the CSF and MRI. Next, we come to the multiple sclerosis, which is a demyelinating disease again. And it is an autoimmune demyelinating disease with periventricular plaques. And histology, we see there are demyelination with preserved axons, and there is this perivascular lymphocytes and foamy macrophages. This all blue small round cells around the vessels are the perivascular lymphocytes, and along with there are these foamy macrophages surrounding this. In the histology, we can see that. And in MRI, we can see that the Dawson figure CSF shows here. This is the bilateral periventricular T2 hyperintensities, which are strongly suggestive of demyelination plaques, which is typical in the Dawson's figure appearance. And in CSF, we can see that the oligoclonal bands here. In the normal CSF, it will be absent, but in the CSF, which is contains the multiple sclerosis patients, in the CSF will be this oligoclonal bands will be present, and the overall IgG index will be increased. Next, we come to the acute disseminated encephalomyelitis. It is a monophasic immune-mediated demyelinating disorder, and this occurs either post-infection or post-vaccination. Again, there will be periventricular demyelination and perivascular lymphocytes, almost like since it is also an immune-mediated condition, similar histology can be seen, perivascular lymphocytes and that reaction. And then we come to the central pontine myelinosis. This occurred due to the rapid correction of the hyponatremia, which leads to central pontine demyelination. Here we can see that the central area of pons, which shows symmetrical, sharply demarcated zones of myelin loss, and these are centrally these are lighter zones, and which are which we call it as myelinolysis, because there is a loss of myelin here, and this region appears pale when compared to this surrounding. This is the Luxel Foss stain, which stains the myelin, and this surrounding area is darkly stained. As we can see here, this central is paler due to the demyelination, which we call it as myelinolysis. And in histology image, we can see that the demyelination with or without inflammation can be seen depending upon the cause. If it is due to the rapid correction of the hyponatremia, then there will not be much inflammation because it is not an infection or any immune reaction. So there will be not much inflammation in the brain. And if there is inflammation, there will be foamy macrophages, reactive astrocytes, and neuronal loss. And there will be also myelin debris, scattered inflammatory cells. And in this image, as we can see here, this is the vessel, and there is a vascular involvement is seen, perivascular macrophages and inflammatory cells we can see here. So this was my presentation for today.
Professor Bennett.
Dr. Umay,
Yes, sir.
you have presented excellent spectrum of neurology and neurosurgery today. You
Thank you.
have covered, you have touched every aspect of it. Great, great talk. I must admire your hard work to collect all these things and present it. Superbly done and very educative, very educative. Thank you. Thank you.
Thank you,
Yes,
sir.
I agree, Professor Umaya. Lecture was really, really interesting and very, very good illustrations. I think will be very useful for not only for students, also for physicians and brain surgeons. Congrats, Professor Umaya.
Thank you, sir. Thank you so much. It's my pleasure.
Okay. You're done, Amaya, right? You finished?
Yeah, yes.
It looks like you were looking around for something there for a little bit. I don't know if you completely finished. Okay, well, so you're done. That's the end of the third complete talk, and we got one next week so that people can watch all four at the same time. So, okay, Amaya, thank you very much, and we'll see you next week.
Thank you, sir. Thank you.
Present, but if you can hang around if you want. And now, and now we have probably one of the most famous neurosurgeons on the planet, Victor Hugo Perez. Victor and I go back a long time. When I first started doing these, Victor, remember, like 10 years ago, I think, eight or 9 years ago, Victor was the first one to jump on board and embrace the technology. It was Zoom back then, but now it's, of course, excuse me, it was Hangout, Google Hangout back then. But Victor's done hundreds of webcasts for us. I put a link in the material that I sent to look at all the webcasts Victor's done on our channel, hundreds of videos. And anyways, Victor, I believe, is going to talk about spinal neurosurgery today. I believe he is. But anyways, Victor, it's all yours.
Thank you, Professor John Bennett. Thank you so much for this kind invitation. So I'm going to talk about neurovascular anatomy and spinal cord. So please tell me if the screen is
Yeah, it's not
good.
yet. It's not full size. It's not presentation mode yet.
Okay, wait a minute, please.
Is it at the bottom, Victor?
Now is good.
Is that the bottom, I believe? Look around, it's there. Is it at the bottom on your screen? I don't know what if you had Apple or do you have Apple, Victor, or do you have a laptop?
Now is
Yes,
good.
perfect.
That's perfect.
Thank you. Thank you. Okay. Okay, I'm going to talk about vascular anatomy of the spinal cord. So understanding of basic vascular anatomy of the spinal cord is very important because imaging interpretation and endovascular surgical management of spinal cord vascular malformations. In the right, we have a picture of a spinal cord. So let me show you next slide. This is a posterior aspect of the spinal cord. In the right, we have the conus medullaris, and this is the lumbosacral segment of this spinal cord. As you can see, we have both paired posterior spinal arteries in the surface of the posterior spinal cord. These arteries are very thin, maybe less than 300 micras, and we can see also the great posterior spinal vein. So it was Albert Adamkiewicz that studied this vasculature of the spinal cord. This is a drawing obtained from an original article in 1881. So we can see the arterial supply of the spinal cord. This is the cervical, thoracic, and lumbosacral. So now in here we can see the cervical supply of the vasculature of the spinal cord. Adamkiewicz used to inject arteries and veins applying a special method using several substances, as you can see in here. But now it's much better and easier. We use some kind of stainings, mainly the silicone, red silicone for arteries and blue silicone for veins. In here you can see the origin of the anterior spinal artery. It is coming from sometimes from one vertebral artery, and in other cases we can see the origin in both vertebral arteries. The right vertebral artery is hypoplastic, as you see in here. So at that time, it was not easy for Adamkiewicz to study the venous system due to its complexity and multiple variants. Here we have posterior spinal cord injected with blue silicone. So complexity is high in the venous system. So I have some examples that I'm going to show you later. So red natural latex was injected into the Adamkiewicz artery under moderate pressure and close visual inspection to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels, including the posterior spinal arteries. Veins were also injected with blue natural latex. So let's see what's happening with this injection. I'm going to repeat this injection. This is the Adamkiewicz artery. So we can see how the silicone goes to very, very thin vessels that are in the spinal roots, the spinal nerve, as you can see in here. So with this kind of silicone, we can reach vessels very, very thin, maybe less than 200 micras. So the great anterior radiculomedullary artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin. The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. Here we have the characteristic aspect of the Adamkiewicz artery that is coming mainly from the left side, as you see in here. So this is this artery has a connection with the anterior spinal artery. Anterior spinal artery irrigates the two superior tiers of the spinal cord, and the Adamkiewicz artery is the main supply for the lumbosacral segment of this spinal cord. So here we have a close view. And the left-sided vessels was present in 45 specimens and a 45 specimens, and a right-sided Adamkiewicz artery was present in 5 specimens. So in this model, we have the right-sided origin of this Adamkiewicz artery, and the left origin was the most important. In these pictures, you can see the left-sided origin of Adamkiewicz artery. This artery is bigger than this other. This is the anterior spinal artery. In all the spines, there is a connection, there is an anastomosis between Adamkiewicz artery with the anterior spinal artery. In this case, we have another picture of this Adamkiewicz artery, and here we have the end of this great anterior spinal artery. This artery ends in the conus medullaris, and it gives rise to three arteries. Two that are going for the posterior aspect of the spinal cord, and one to the conus medullaris. So in here, this is a very nice picture to see the end of this Adamkiewicz artery. This is the conus medullaris, and although variability exists to the caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important radiculomedullary artery is the arteria radicularis magna, known also as Adamkiewicz artery. This artery arises in the thoracolumbar region between T8 and L2 in 75% of patients, and has a diameter of approximately 1 millimeter. As you can imagine, 1 millimeter is very, very thin. So we have to make a good injection in order to go to a really, really thin arteries that goes with the nerves. So here we have the conus medullaris, two posterior spinal arteries, and one artery going to the filum terminalis. This is a lateral view of a variant, anatomical variant in the conus medullaris. So here we have not only one artery that is going to the posterior aspects, also two. We have two arteries, and here you can see this complex. So the difference between thoracic artery and the Adamkiewicz artery is very, very important. In this picture, we can see the Adamkiewicz artery, and then in the superior picture, we can see the thoracic artery. This is almost 200 micras, and this is 1 millimeter of diameter. So the preoperative localization of this artery is very important in surgical transthoracic spine, and the anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. Adamkiewicz artery, in this case, is arising from T3. It was the highest level in this study, about 50 spinal cords. So here we have the first cervical nerve, 1, 2, 3, 4, 5, 6, 7, 8. This is the 8th cervical nerve. And then we have the 1, 2, 3, the third thoracic spinal nerve. So this artery was arising from this level. It was the highest level. So here we have another picture to see the thoracic aspect of this spinal cord. And in here you can see a close view of this slide. So In this case, we have the lowest level of the Adamkiewicz artery. It was arising from left 12. So here we have the cauda equina and the Adamkiewicz artery. So in the next picture, I displaced these nerves, and we got a really beautiful view of irrigation of this lumbosacral segment of the spinal cord. Here we have the Adamkiewicz artery in the lowest level, as I have told you, and the spinal vein. So here we have the anastomosis between these arteries. In the superior, we have the posterior spinal arteries, and in the inferior, we have the Adamkiewicz artery. So here we have connection between arteries and also veins in the lateral aspect of this spinal cord. So this is a table to show the level of origin and the size of the artery of Adamkiewicz. It was most frequent in T9 in the left side, and in the right side it was T10. So in here, in this case, we found two Adamkiewicz arteries, this and this, and this is a radiculomedullary artery, very thin. We do not consider it that this is a third Adamkiewicz artery, but we have in this case just two. So anatomy of the great posterior radiculomedullary artery. This is a really interesting artery because in 70 years ago, it was not very well recognized, this artery. So this is a posterior aspect of the spinal cord, and this is an illustration of the arterial radiculomedullary supply to the spinal cord. A posterior view of the distal spinal cord demonstrates the radiculomedullary supply of the distal cord. This is the anterior aspect with the anterior spinal artery and posterior surface of the spinal cord, showing both two paired posterior spinal arteries. So the supply of these arteries is sometimes the posterior radiculomedullary artery and also the great posterior radiculomedullary artery. So this is very important. The existence of a great posterior radiculomedullary artery has attracted little attention and has been a matter of debate. Various authors postulate such a vessel. For example, Gillian in 1958, Lasortes, Romanes, and Jellinger in 1966. But look at this. Others do not mention it or even deny its existence. For example, Domis in 1980 do not mention this artery. So as I told you, some authors denied the existence of this artery. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of cases, but its caliber does not approach that of the large anterior vessels and is very thin, this artery, almost 300 to 500 microns. Its height is more caudal than that of the anterior radicular magna arteries. So this is the great posterior radiculomedullary artery. We found this artery in almost 75% of cases. And this artery is very important for the supply of the lumbosacral region of the spinal cord. Let's go to see this video.
This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery.
Another video.
Here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery.
So, great posterior radiculomedullary artery was identified in 72% of these spinal cords, and the total included specimens in which unilateral and bilateral GPRAs were found, as well as a single case in which 3 GPRAs were evident. In 26 of the specimens, a unilateral left-sided great posterior radiculomedullary artery was present, 13 from 50. A unilateral right-sided was present in 22% of the specimens, as you can see in these pictures. So here we have the lateral aspect of this spinal cord, Adamkiewicz in the anterior aspect, and this radiculomedullary artery in the posterior aspect. As I told you, these arteries join, they are joining in the conus medullaris in the lateral aspect. So in the inferior picture, we can see this great posterior radiculomedullary artery that is almost the 50, is almost 500 micras. So it's thinner than the artery of Adamkiewicz. In 22% of the specimens, bilateral GPRA were present, 11 from 50. And the great posterior radiculomedullary artery in one specimen demonstrated 3 GPRA. This is the table of distribution of this artery based on side and spinal level. So it was common in the thoracic nerve, in the T12 thoracic nerve with 9 cases, and in the right-sided in 9 cases. So this is most frequent in this segment. So there is no doubt about its existence. The GPRA is coming from left T9 in this case. So this is the lateral aspect of the spinal cord. This is the dentate ligament, dura mater, and pia madre and arachnoid. So GPRA is conclusively present in most 72% individuals. Understanding this intricate anatomy and its variation is critical for several procedures. So in these pictures, you can see these arteries in the posterior aspect of the spinal cord, very, very thin. So let's go to see some veins in these like in these videos. So the complexity of the vein system of the spinal cord is not easy to study because it's variability. It has a great variability, and we have for example, in the superior video, we can see just two or three three veins, and in the inferior we have too many veins for the like in here. So here we have 1, 2, 3, 4, 5, 6, 7 veins to the venous flu, and in the superior only 1, 2, 3. So let me show you again these videos. I think they are very important to understand the variability of these veins. The return of the venous flu, like in here, 1, 2, 3, and in the inferior, the complexity is more important. So this is the great spinal anterior vein. The average diameter is 0.8 millimeters. The posterior veins, in this case, you can see the variability, the anatomy variability, more complex than in the arterial structures. Posterior spinal vein, 1.48 millimeters in the posterior aspect of this spinal cord. So posterior spinal arteries in color red, and look this anatomical variant of this vein. So these features was published in the American Journal of Neuroradiology. It was made with Dr. Hernesniemi and also Dr. Juan Small. I think is the last picture. I think I can show you the arteries of the cervical and thoracic segment in the next lecture. I think they are very important in surgical procedures. So thank you so much for your attention.
Thank you, Victor. Saying that latex, most neuroanatomists don't inject latex, do they? Because it's so time-consuming and difficult.
Victor,
No, I don't think it's not difficult. It's very, very difficult to inject the very, very thin arteries. For example, vessels less than 100 microns is very, very difficult. But I use another technique to inject these small arteries. Big and medium size of arteries with latex or silicone. But smaller vessels, I use paint, industrial paint.
Okay, Harshad, do you have
Victor,
something to say? Go ahead, Harshad.
Victor, wonderful specimens and videos superbly demonstrated. And this great posterior radicular artery demonstrated so well in the conus. Can I ask you one thing? Suppose by mistake you coagulate this artery, is the patient is going to develop paraplegia or something like that?
Yes, especially in some surgical procedures, for example, surgery for aortic aneurysms of the aortic artery in the abdominal part of the aortic. You know that these vascular surgeons put some clamps to treat these aneurysms, and these are of a high risk to produce ischemia in the lumbosacral segment of the spinal cord. So I think that's the reason the vascular surgeon and also spine surgeons should know this variability of irrigation of the lumbosacral segment of the spinal cord. Of course, if one of these artery is damaged in those surgical procedures, we can get paraplegia in the patients.
Very informative, very informative. This is something different than normal vascular anatomy and wonderfully demonstrated. And it's your hard work. I've heard you many times and seen your videos and specimens. You are really doing hard work and teaching us about the anatomy of the spinal cord. Great job. Thank you very much.
Yeah, Victor travels all over the world. Can you just tell us how many places you've been to in the last couple of years, Victor? Indonesia, India, Pakistan. You've been all over the place the last couple of years, right?
I had the opportunity to go to Surabaya, Indonesia, and also Kuala Lumpur in Malaysia, and also in last 2 weeks I was invited to show this a lecture to Cambridge University in England. So I think this information about vascular anatomy of the spinal cord is very important to know.
Great.
Yes.
Great, Victor. Thank you very much. Okay, we're going to move on to Bhushan Thirambi from, he's from Mumbai also, I believe. Anyways, he's going to lecture today on practical utility of available AI tools for neurosurgeons, which today I don't have to tell you how important AI is in understanding almost anything. It's growing so fast, and it has applicability to the science of neurosurgery. And so I'm looking forward to hearing from Bhushan. Welcome, Bhushan. It's all yours.
Hello, Dr. John. So thank you for inviting me here today. I will share my screen. Okay, so is it visible?
Yes, perfect.
Okay. So so today we will be discussing about tools which we can use as a neurosurgeon. Like many people have already started using many of these tools, but to use them properly is of utmost importance in today's world. As Dr. Chandrasekhar Devapujari sir has shown, time changes very fast. Like within last 20 years, so much technology has changed just in neurosurgery that like we feel it almost unbelievable that this much can change in so much less amount of time, and we have to keep adapting to these changes. Otherwise, we might not do best for our patients as well as to ourselves as a neurosurgical practice. So we need to be very careful about all these things and keep updating our knowledge. And no doubt there are a lot of technologies with like 3D modeling, simulations, and one of the great thing which is coming is artificial intelligence, which we must embrace today in our practice to get ahead of a lot of complications uh, 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 and the newer techniques which are coming to avoid a lot of problems while dealing with our patients. So today we will be seeing a practical utility of currently available AI tools for our neurosurgeons, and mostly these are for surgeons who have not started using it or who have started using it and want to upgrade it to next level. So we will go from easier tools to advanced tool throughout our lecture. The today's agenda will be to discuss about what are the current available tools, how we can make them useful, just not in for patient care, but how to promote it over social medias and how to communicate with each other, and what are the limitations based on that. So this is a small analysis where how many neurosurgeons use social media. So particularly in global context, almost 65% of neurosurgeons use social media today, and 88% in India particularly use to display their cases or to communicate with each other. And we have to use AI tools to communicate in such aspect also. So should a modern neurosurgeon use AI? Of course, many won't disagree with that. But how to use it and how to do it adequately, many people won't know it, where to start. So today's lecture is all about that, and to get started with you on this AI bandwagon. I performed a small study where like I collected all papers based published in neurosurgery in terms of AI tool. With a small tool I developed myself called PubMed Article Downloader, and it has given me like almost 5,600 papers, 6,000 papers, which are published in artificial intelligence and neurosurgery. I included other terms like machine learning and other related terms also. And when I analyzed that and calculated like where from most of the papers are coming, majority of them are coming from China, Germany, Canada, and Japan, and United States too, but very less are coming from India. So we have to focus about how we can learn to use those tools first of all, and then how to publish and make a study out of it so that we can publish and go ahead out of that. So it's very important for a young generation and neurosurgeons to get hand of it in early time, so that in the next 5 years we this chart not look same. So I have another lecture where I have explained with Dr. John before, understanding the basics of AI, where I have discussed all the technical details and algorithms which we use in artificial intelligence. If you want to have these basics and revised, you can go to this QR scan and get it revised. But today we won't be discussing that. We will be discussing the tools which are currently available and we can use it today pragmatically. So if we find there are a lot of clutter there, every day new tools are coming, and many of them are just overlaps over the basic tools like the APIs. Most of these tools use APIs, and the basis are based either on the AI models from OpenAI or Google, like Gemini models or Palm models, and but the utility on the top of that is amazing. Like you can use ChatGPT, Perplexity, Copilot, GitHub Copilot, and it will give you almost similar look, but every tool is like curated for different things. So first of all, the most commonly used tool, ChatGPT, we will learn a few basic things about it, and it is like must know for everybody, and almost everybody in today's world knows how to use it. But for those who don't, like you can go to chatgpt.com, log into yourself, and start using it outright. Okay, so it is an LLM based, like large language model based model, where you like put something as an input and you can talk to it like a person. Particularly using these tools for medical data can be quite challenging, because there is always a possibility of a data leak into the training data set. And when, if you are like using these tools, your patient's data might get leaked for the next training model iterations. So there are very few things which we can do for that. The first of all is, like, if you are using like ChatGPT or DeepSeek like model, you can go to the data control tab into their app and just switch off to which allows to share the data. Like so it's like a basic thing to do, and it added some kind of protection for you to move forward while using this kind of tools for your medical data. These are the simple tools, the one which are like every day they are giving new tools, like a data analyst. We can search web, we can do a deep research on a topic which we give. We'll discuss one of the utility of that in current lecture also. There are agents which are now published yesterday only, where you can like give a specific task to those agent, and you get to know about those tasks. Like one agent will do a particular thing, like just for analysis of image. Another agent will analyze the reports generated by that agent, and the next will communicate those things to the patients. And you can do all kind of things with these new models. That's very exciting. It just published yesterday. So in the deep research thing, it is a small tab where like you can go and ask him to communicate a topic, and it will analyze all the available data and summaries. Like there are thousands of paper there for each and every part. You can just give it a topic, and it will generate a lot of summary for you and give you each reference. So the hallucination problem in this LLM models is getting taken care of, and you can always go and check from that reference of lines where that data is coming. So you can do like historical development of trifinations, quantum computing in neurosurgery, and whatever available data is there, it can give a nice summary to you. So I can show you an example here where I asked him to analyze the data for Indian neurosurgeons, and it has developed a lot of things for us. Which are the pioneers in 1940s, like Dr. Jacob Chendi, Balasubram Ramamurthy, and all of things like what are the maturation stage in 1970, 1990s, what has happened, how the Niemans and Ames came into the picture, and what are the contemporary leadership, the contributions by great neurosurgeons like Atul Goyal sir, Parik Doshi sir, Sarat Chandra sir, Chandrasekhar Devapujari sir, which we have lucky to have him today with us, and like that. And all of their contribution is summarized nicely in like 15 to 20 minutes, which would have otherwise taken me like a week or two for reading through it. And every referenced, and I can go to the published articles and see where that data is coming from. So I'm sure that there is no hallucination in that. So it's a very beautiful tool. I encourage everybody to use it. There are limited limits how many times you can use it. So there are like 10 to 20 times you can use it in a month in a paid package. Similarly, there are specific tools like GPT tools like SciSpace, Scholar AI, and Consensus, which will summarize all the published papers and literatures for you in a particular topic, like say hydrocephalus in neonate or vasculitis in a patient with EVD, and you can analyze that data so that the time what you can spend more on actual research and rather than just doing the skirt work of collecting all the papers in the literature can be reduced by weeks altogether. So I will highly encourage everybody to use this kind of tools to summarize their data. Similarly, there is one tool for getting an idea about how you can analyze your data, what are expected results, and you can use this kind of tools like to analyze data. I'll show you one example where I have used like a stroke patient's data. And there are like 2000 patients which are analyzed in this chart sheet, and it is a like a master chart which we generally developed at the end of our study, and it can help you design your study better. Like here you have like these dependent and independent parameters like a stroke as a target variable, and these are all the independent variables which we are trying to analyze, and it will summarize it for you, do a descriptive analysis for you, like there are 2,900 females, 2,000 male in this stroke data, how many were married, whether they were smoking or not, and it will analyze it for you in just a matter of minutes. So before going to the extensive analysis, you can get to know how your data is distributed all over the stuff. It can suggest you what kind of predictive modeling you can do, and you can pick it from here. It can go to the next steps also. It can do and generate these beautiful charts for you, and it just in a matter of minutes, like how is the age is distributed, how is the BMI is distributed in your patients, and how is the average glucose and other stuffs. So it's like really useful for you. Similarly, it can do clustered analysis for the patients who are smoking, who are married, who are male and female distribution, and it will give you some kind of idea before proceeding with your actual analysis. It can do some actual analysis also, but I will highly suggest to check it back, and it can tell you like what are the relationship between BMI and stroke, like with glucose and stroke, and 99% of the time it's highly accurate with the current models of like 4.5 GPT model, and I have like almost find it's almost never wrong, but it's highly dependent. You should always check. And this is about the data analyst. So now going forward, there's another tool we will now touch about is called Notebook LM, which is by Google. And it is very important tool if you want to learn new things. There is a ton of data available, and majority of them have a similar kind of data. And if you want to analyze and segregate them one by one, it's very difficult. So what you can do is use this Notebook LM tool, which is by Google, and here, like say, if I want to study a cerebrospinal fluid leaks, their diagnosis, management, and how was the patient experience, I can put all kind of articles which I have which I want to analyze, and or I can have my own kind of data. It can be from your Google Drive, so it is safe and it's not shared with other tools. You can also put a website and YouTube videos which are there, or you can paste your own text also. And once that is done, it will analyze the data for you, and it will give you a lot of things to go ahead. Like you can ask it like to classify how there is a difference from CSF leaks and how it is managed. It will give you a nice summary based on all these articles combined together. Also it will like give you like management tools, and it's everything is referenced. Like you can go and see where from this line or the information is coming from, so that you can recheck all the work done by this kind of things. It's very useful for learning new thing as well as to analyze your own data. And sometimes people are like audio learners rather than the reading or just so it has developed a similar kind of tool where all this information is segregated in terms of narrator and interviewer type of thing, so that you can learn this as in like whenever you're driving, you can just play this off and all this data will be summarized for you. Like I will just play it for 5-10 seconds to just get an idea. So it will go through all of the details and actual facts which are there in all these articles, and you can just listen to them and learn them all. Similarly, if you're a visual learner, it can produce mind maps for you. Like this is the CSF leak overview. What are the different causes? What are the different symptoms? And what are the various treatments available? It will summarize for you what are the various surgical techniques are there to repair it, and what are the various prognosis for you, and it will summarize it for you in a mind map technique. So it's a great learning tool if you want to learn newer topics or to revise something or have to make yourself familiar with newer tools or newer techniques which are coming in that particular field of neurosurgery. So these are two basic tools. There are other tools like video generation tools, where like if you want to use it to publish something like on a social media, you can use these tools to generate such kind of pictures, which might take like hours of your time to set forward. And Dr. John knows how to use them, and he uses it very perfectly every time. And this type of tools can be used very nicely for this. Similarly, there are upcoming video tools like Sora and Google Vivo, which help you produce the pictures based on what you want to do. Like imagine like you want to show in your conference, like what are the dangers, or you're going lecture in the public and you want to show how helmet wearing helmet awareness program is supposed to work, and how there are things like I can give details into this. And once it produces the picture, you can see such kind of videos generated, and you can use them without any copyright. But currently, as you can see, they looks very weird and funny, and you can tell it just by looking that they are generated by AI. But the thing is, these are the models from Sora. The current model Vivo, it's not currently available in India, but it will be available soon. And the picture quality and video quality with that models, it's astonishing. So the next thing we will discuss is audio generation tools. Many a times we know that what we want to express, but we don't have time many a times, or we don't have a script to do it. And such kind of tools are available for us to get into that things like you have video and you want the audio explanation for that surgical video. So you can just simply go ahead, or if you want to make an educational content for your patients while they are sitting in your waiting room, like about intracranial pressure, raised intracranial pressure or something like that, you can just put it and ask ChatGPT to develop a script for you based on your articles from the previous methods what we used, and you can put it in the tabs. Particularly I have used here the 11 Labs IO app, which like give you a very good tool. The audio is astonishing.
Intracranial pressure, or ICP, is the pressure inside the skull, exerted by brain tissue, blood, and cerebrospinal fluid. Normal ICP ranges from 5 to 15 millimeters of mercury. When it rises due to
and you can use like various audios for that.
Timely intervention is crucial because in neurosurgery, minutes can save lives and function.
So as you can see, these audio tools has become so advanced that it becomes almost impossible for us to distinguish it from a real professional video. So I highly encourage while you are presenting your videos, you can use these tools to have a narration for better understanding, and you can add different voices, different languages also. As you can see, like if your patient target based is let's say understanding Hindi or Kannada, and you can just easily translate it, and they are happy to go into that language too. So it really break the barrier of language.
Intracranial pressure यानी मस्तिष्क के अंदर का दाब, ये दिमाग के ऊतकों, रक्त और सेरेब्रोस्पाइनल द्रव CSF से बनता है.
So as you can see, these tools, audio, video, textual, and data collection are really important for you if you want to learn and start using AI into your daily practice. You can do a lot of things with these so basic tools, which we take for granted, but there are so many things. Like if you have like hundreds of patients in a particular disease, you can just try to put it and have an ongoing analysis of those data rather than waiting till the end to analyze all at a time. And you can, like every week, if you have like adding some cases, you can analyze your data, how you're doing, what are the complications, and you can all analyze them in a repeated ongoing pattern rather than to wait at the end of the year or two to analyze all the patients together, because it's so cheap and it's so easy to do it. It's really a possibility just with AI. Now we will go to some advanced tools like image segmentation and classification tools. In this, there are like you have to do a lot of work to use with such kind of tools. Like from data collection, you have to prepare the data, annotate, label many a time, resize them to fit a model, and then train them on those kind of model, do a developmental cycle, and then publish it so that you can use it on a repeated basis. So there are hard ways and easy way to do this kind of thing. The hard ways are like from using a tensor flow or PyTorch kind of libraries. So this is the way I do it. I use all kind of programming from Python to Dart and all, and I code all this kind of things, and you can analyze and then label the part of you are interested in, train that data after labeling, and then model based like this. There are different convolutional layers, and then train and regrind and do a lot of things, and it takes a lot of time, but the models have a lot of control. It takes a lot of time to build them and deploy them, but the end results is completely in your control, and you can modify it to whatever you want it to be at the end. But there are some easier tools if you just want to classify, let's say, between the EDH and SDH, or if you want to classify between is there a let's say surgical option to be given to this patient or not, or something which are like univariate classification system is there. Or if you want to like segregate some kind of thing, like you want to label like pituitary tumors in the given CT film, such kind of task can be easily done with these tools like Neptune AI, where you go and label, like in this photo, you can go and draw this like things with different colors to identify your tumor here, and you can input such kind of like 100 images into these models, and they will choose the model for you, and it will give you the results based on like such kind of a square boxes, or there can be a diffuse boundary also along with this, and it will help you generate your data classification and data segregation system, image classification or image segregation system. It's easier than to programming, but it still requires a lot of time than the tools what we have used before. But it's really satisfactory, and there are tools which you can use it in the current world. Now coming back to other things what we can do, all those things comes with limitations and precautions. As I have told you, you cannot enter your data directly. You have to be very segregated. The best thing you can do is to run it on your local computer, but sometimes that's not possible at all, because training this image-based classification or using this LLM takes like a terabyte of space, and that's just not possible on your current systems. Similarly, the GPUs they use are really high end, and if you want to train it in a feasible time means in terms of weeks, you have to use cloud computing based networks for that. So now coming particularly the other tools which are there but are not that publicly available, but you can build something for yourself if you want to. You can use it in your surgical workflow, like for radiomics, diagnosis, decision making, pre-surgical planning, simulations, monitoring and follow-up. Similarly, in non-surgical workflow, you can integrate AI today with these tools what we have discussed without much overhead, like with using patient's behavior, how to follow them. You can just add a bot and develop a bot for them, for your patients to follow up, and all which are important questions are there. They can be asked to the patients on the follow-ups, and just the limited information comes to you, saving you and patient's time during an actual phone call. You can do summarization, manuscript writing, helpful with that, although there are a lot of things which you have to be careful about while using it in manuscript writing. So these are some of the tools which are published, like for diagnosis and radiomics. You can see how beautifully this fractal analysis of the vessel is done based on an MRI. There are volumetric tools available to classify your tumors and how they are growing, or particularly in cases which you want to follow up on a yearly basis, like with small tumors, meningiomas, or which are calcified, and you want to assess whether they are growing or not. And you can use this tool, avoiding use of time which can be used on other things during your practice. Similarly, the imaging genomics is coming a high way, where like just based on imaging, you can know the IDS status, MGMT status with a high accuracy as high as 94 to 96% with various tools. And you don't need to wait till histopathology comes up with IDH studies to know and decide about the prognosis of your patients. This is one of the tools which is publicly available. You can go to this website and developed by Harvard Medical School, and you can enter the AS, X-rays, and all kind of tools, data about your patient, and it will give you the prognosis expectation for that patient, particularly in who is having glioblastoma. And it's no more generalized a prediction, but a specific prediction just for that patient based on the evidence. So I again highly encourage to use such kind of tools while doing prognostication on your patients. Similarly, this can be tools for meningioma gradings and other IDH kind of things. In traumatic brain injury, you can use such tools for identifying whether there is how much a prognosis can be in different grades, like A, B, C, D, E, F, based on the unsupervised models and other models. This is one of the publication I did, where a squash is obtained from the glioma tissue, and within like 2 minutes in intraoperative time, we can get whether the tissue what we have obtained from that squash is either high grade or low grade glioma, and we can distinguish it to how much margin exploration we can use, or and how much tumor or how much normal brain tissue we want to avoid resections and all such kind of thing. Generally, this takes like 30 to 35 minutes in very advanced centers too, but with 2 to 5 minutes of time intraoperative, we can do it repeatedly, and it will help us avoid decisions intraoperatively whether to resect that tissue or not to resect that tissue. This is another tool developed by based on the Raman spectroscopy in the similar aspect in neuropathology. This is called as a fast glioma, developed at Michigan Hospital, where you put a tumor and it will analyze it for you using a Raman spectroscopy and give you the results in a similar kind what we did with general microscopes. Sometimes, many a times, you don't know if the patient has been operated outside and your records are not available, which happens many times in India. You can have this kind of X-ray tool and it will identify what kind of metal or what kind of screws are used in the previous surgery, so that you can make a revision surgery is easier with the next surgeries. These are the specific tools, specially developed GPTs for like vestibular schwannomas, NeuroGPT X, and it will tell you and answers you all kind of questions related to the vestibular schwannoma. It's a wonderful tool if you use it. Similar tools are all available everywhere, like this NeuroGPT X, where as I told you, you can ask him the questions. I will again encourage to use these tools in non-surgical workflow, as I had demonstrated before. And but while using it, you always need to be aware about what are the downsides of it. Like there are direct disadvantages of using it, like having inadequate training, always fearing that you are having poor understanding of the basics, that you are missing something, even though you know that this is the diagnosis or this is the thing. You might develop self-doubt and just go to recheck the things based using these tools, and miss the time, which will defeat the purpose of like saving the time instead. And many times these are the algorithmic black boxes, particularly the vision tools what we use, and we don't know actually how the decision it has came to, or how this information has came from. So it always helps to contextualize such kind of things and develop a model based on just single things to avoid such kind of mistakes. There are other long-term disadvantages, like if you overly rely on such kind of tools, it can cause de-skilling, can make you overconfidence where you should really not be, and it can cause lack of necessary vigilance from the seniors, who usually will take efforts to make sure whether you are as a junior neurosurgeon you are doing it correctly or not. So you have to be like very careful while using such kind of tools. So that comes to the conclusion. Thank you for hearing me out today. And as you know, deep learning is artificial intelligence is a huge area where you can progress, but you should always know your statistics first, because everything is generated from that. So don't directly jump to the deep learning. Understand your stats first, then machine learning, then you can explore other tools like deep learning and all to use it in your clinical practice. So thank you, everybody. If you want to read further, you can go to these websites and have a small talk about it. Thank you.
Thank you, Bhushan. Excellent. I love this topic. It's so new. Well, it's new to me. I know it's been around for a while, but the applicability, the thing that really fascinated me, Bhushan, was that you can go in an article, and any part of that article, you can explore that part of the article with ChatGPT and go in a totally different direction and keep going. I mean, that's a fascinating thing to me about it. So, Victor, do you use AI much or in neuroanatomy or no?
Well, it's a new tool around the world. So I use this for only a few things, but I think it's the future. Very nice topic, Professor Bhushan. Not easy to understand, especially for old people.
Well,
For
Victor,
for young people, is very easy to understand this this technology. But I think it's going to be now is useful, but in the future, I think that is going to be indispensable. So very, very useful for all the disciplines, for all the science.
Well, Victor, you can use it for imaging too, Victor. I don't know if you knew that.
Yes, think so.
Yeah, images, it does wonders, really. For me, it saves
Yes.
time. It saves time. I can make a description of what I want. And I used to spend time on Photoshop. I don't know, Bhushan, if you do Photoshop, which is a good accessory to AI. You can kind of polish off your images. But I'm surprised at how well and quickly it does images. It saves me time as far as getting articles.
Yes, I agree, Professor Bennett.
Okay, any more comments or questions for anybody for this fascinating field of
No, just to congratulate Dr. Bhushan. Very nice lecture.
Thank you, doctor.
Yeah, I think we went over this before. You've been into AI for a long time, right? Probably when did you first start with AI, Bhushan?
So it's been like my ninth year of starting programming in AI. I started from basic during my medical school, and from there I'm like working on it slowly. I have been programming since childhood, but particularly the AI program I started around 8 to 9 years back.
Yeah, there's a lot of work to be done. And we'll talk later about having done privately. Because I mean, obviously it saves time if you use it effectively. I've got to use it for the website actually to use it effectively and to somehow analyze the data I've collected over the years. We've had 3,000 videos we've made, and I think Victor's made about 200 of them, almost or 300. But uh, how is it with analyzing videos, like content of videos? Are there any AI tools to use that you can somehow analyze the data in a bunch of videos?
So yes, there are tools. What we can do is like if you have one video, it first has to like segregate audio and video part of it first differently, and it will analyze the audio content first. And once that audio is analyzed, we can go to that particular time in the video and focus on the topics and can show a small clip. There are a lot of things what we can do with a single video. So we have to like first develop maybe a step-by-step algorithm what we want actually at the end, and then plan about it how to start analyzing and which tools we can use to achieve that goals. Like if your goal is just to summarize the video, that's an easy job. But if you want to have linked to that part of that video, and like by clicking, let's say in the today's talk, if we want to go back and just there is a line like using AI tools in vision, and you have to link it to the image slide which you have published. That takes a lot of time because you have to summarize the audio and then link it to that section of the video. So that's gonna be different project altogether rather than just summarizing. So what's our end goal are, depending on that, we have to decide what tools we have to use.
So you could summarize a video pretty easily.
Yeah.
And summarize a video down to 2 minutes or 3 minutes or whatever,
Exactly.
whatever variable you want to apply. I mean, yeah, there's so many applications, so many things. Well, I appreciate your time, Bhushan. Maybe we'll talk after a little bit. And I certainly want to use it for my own purposes of web development. And I guess it's affected jobs with programmers and coders, right? A lot of coders aren't needed anymore because you can use AI, right?
Exactly.
Yeah, like some of the big companies, they hire AI, and then once you make the program, they fire them.
So
They've got their output, and that's it.
yeah. So, Dr. John, many talks I have heard about like losing jobs and what kind of things are going to be in future. But I have always realized at the end of time, the most important thing is that people who wants to do something don't know actually what they wanted. That's why maybe we are thinking that the jobs are gonna go that sooner, but they won't go because although let's say somebody wants to build a website, they know that they want a website and they want what kind of structure it should be, but actually and there are tools available to build that kind of things, but the integration between them two is still unknown to a person without giving a significant time in actually understanding that structure. So maybe the coder's job will be easier, but they won't go like a painter is there. Like even if in a chat GPT, if you want to do something, you know how to do it. Like if you want to create an image, still you have to describe each part of it separately to get an ideal picture, and still it gets wrong many a times today. So the thing is not maybe to have these tools, but rather actually what you want at the end. It's more difficult to contemplate in your mind rather than knowing how to use those tools. Like having a Caesar is very easy, but actually learning it, how to use it to tailor to your advantage is a much difficult task.
Yeah. Now, when did you learn Python?
Oh, that would be in 2007.
Now, did that help you in understanding AI?
Yeah, of course. Like in today's world, 80% of the AI tools use some kind of Python as a backend, or at least understand, or it makes it easier to use. The AI is not a very deranged field. It is like there are no common platforms. So Python works as a connecting language between all these kind of tools. So it really helps you to know Python to help you use all such kind of tools and have a proper control over what it actually do.
So would you suggest, say, for a student that it would help their understanding of AI if they learn Python first, or would you suggest you really don't need to use it now? Tools are kind of made to use without knowing Python.
So actually that depends, like what are your end goals? If you just want to use it, then maybe you can avoid learning Python, because if there is already tool available and you can modify it in somehow to specific your need, then that's all. You can like have that kind of thing, like say an image analysis, and you can use the tools available today. You need not go into Python. There are visual learning tools available. But if you want to build something new tool altogether, then you must learn Python or any other similar kind of languages. So it depends. Like if you want to build a new tool altogether, then learning these languages is a must. Otherwise, it's optional.
Well, really, if you think about it, you could have, like, say, Victor make a presentation on a spinal anatomy. You could actually imitate Victor, right? You could take his face and you could use a program so that Victor actually is using his voice and his image, giving a summary of the video he did in the future, not now. You know what I mean? Like the Victor just did a video. Okay, say, okay, we're gonna have Victor use his voice, the way he talks, use his face to give the summary of the video he gave. You know what I mean? With permission of the person, of course.
Yeah. So you will be surprised that's possible today, Dr. John. Like the website I told you, Elevens Labs, it has a models where you can train your own voice. You can just give him some audio clips of yourself or video what already you have done, and it will train on your voice, your way of your way of talking, your accentuations, your accent it will pick up, and you can just give him a next text, and it will speak out like Dr. Victor. So it's really possible in today also.
Yeah, you could make a video without you use an old video, say,
Yeah.
and then repurpose it with AI to a length of 2 minutes, 3 minutes with your face and voice. I mean, that's a good marketing tool. And I'm
Of course.
sure people would agree to it. They would, of course, you probably have to have some kind of permission if you're going to use their image and their thoughts and, whatever they're talking about. But once they say, yeah, sure, it would help me, it would save me time. I don't have to do a promo. We've got the promo made. You know what I mean, Victor? Or I'm being crazy.
Yes, agree.
No, I can take one of your videos, Victor, and make a promo of it with your face and your voice, and you don't have to do it. I mean, it saves you time. You know what I mean? That's where we're heading. That potentiality. So,
Yeah.
anyways, we'll get off the air, and thanks a lot. And stick around for a second, and we'll chat a little bit. So, thanks, everyone.